Next, I'll invite Dr. Ben Buchanan up to the stage. Ben is a clinical psychologist who works exclusively with people with body image and anxiety and BDD, and he's currently focusing on the intersection between BDD and cosmetic procedures. And today, Ben will talk to us about screening for body dysmorphic disorder and other conditions. Thanks, Ben.
Thank you. Well, it's really great to be here. There are only a few psychologists that work in this space, and I've been working with BDD for over a decade now, where I did my doctoral research, where we got a whole bunch of people with body dysmorphic disorder. We put them in an MRI scanner to have a look at their brain, because we really wanted to know why people that looked normal from the outside, and even quite attractive people, had this intense sense that they were ugly or disfigured. And since then, there's been a wealth of research into the area. So my disclosures, I'm a psychologist. I'm also the co-founder of ReadyMind. I think there's some information on your tables about that. And I'm also the co-author of the Cosmetic Readiness Scale, which I'll be talking about. So what is body dysmorphic disorder? Well, it's an obsessive preoccupation with appearance, where someone looks normal or maybe has a slight abnormality, but their concern about it is exaggerated. BDD can really ruin people's lives. I've been seeing people with BDD for years, doing therapy with them, and I've met people who don't leave their home because they've got BDD and are too anxious about what other people will see. I've also met some celebrities who are very good looking, who are out on stage, but deep down they think they're ugly and hideous and terrible, and it causes them a lot of anxiety. So BDD comes in all shapes and sizes, and people with BDD really do see themselves differently. And some of the MRI research that we did a decade ago showed that there's some visual processing differences. So it's important to think about what BDD is not as well. Here's an image of my colleague, another psychologist, Dr. Toni Pikus, who works in this area, and she's used a filter, I think on Instagram, to plump up her lips. But we can't tell from just looking at someone whether they've got BDD or not. BDD is not when someone just looks overdone or looks like they've had too many procedures. That might be a sign of something, but BDD is really invisible. You just can't tell who has it without really talking to them. BDD is not just simply vanity either, and it's also been around really for centuries. It's not a new phenomenon. And BDD is different to just run-of-the-mill body image dissatisfaction. We all have a sense of dissatisfaction about some aspect of our appearance. BDD is not that. BDD is that on steroids, where it's really impacting someone's social life, their work life, or other important area of functioning. And some of the main areas that are common for people with BDD to be fixated on, and I think I've actually got the man and the woman mixed around. Women are usually fixated on their skin, which is why we're here talking about probably skin is the most common fixation. Nose, stomach, weight, chest, thighs, hair. And men, it's often genitals, hair thinning, how muscular someone is, their height. I've met people who have gone overseas to get their legs broken and a leg extension because they're so concerned about it. Excess body hair and body proportions. And us human beings are intensely visual people. A huge proportion of our brain is devoted to our vision, the occipital lobe back here. And seeing really is believing, and it's incredibly difficult to try to convince someone with BDD that they in fact look normal. I imagine that some of you have probably seen people in clinic where where you think they look normal, but they're telling me that they look hideous. Like, where's the disconnect? You won't have much luck telling them that they in fact look fine. And sort of to demonstrate this, here's an infamous picture of something that is obviously a black and a blue dress. Who here sees it as black and blue? Black and black and blue? Who here sees it as white and gold? Okay, so most of the people with their hands up now, obviously you've got a problem with your brain. Only kidding. I mean, this is an image where even when it's demonstrated to us that it's a visual illusion, and we actually, if you look at the apron, for example, that apron, it's the same color on each side, but it's the background which causes us to see something different. And no amount of convincing you that it's actually white or yellow or whatever will change your visual perception. And the same goes for BDD. You just can't convince people with BDD that what they're seeing is not real. And in this particular visual illusion, it's actually the background and the overlay which is causing that illusion. And also with people with BDD, they've got their own backgrounds. They've got their own overlay. They've got their history of trauma. They've got that bullying. They've got that parent who always commented on their appearance growing up. They've got a whole bunch of stuff which is their background. And so why are we talking about BDD? Well, it's because people with BDD often have some pretty bad outcomes when it comes to cosmetic procedures. I imagine that many of you have had sleepless nights because there's this one patient on your books that you know is just dissatisfied, that you know the treatment wasn't, in line with what they wanted. They keep you up at night, you worry about them. That person may have had BDD. And the research shows that about 80% of people with BDD have no change in their symptoms after getting a cosmetic procedure. Even though they'll tell you, if I get this blemish fixed, then I'll feel happy, then I'll feel relaxed. 80% of the time, that's not the case. And 80% of the time, they continue to worry about the treated area. 17% of the time, they just switch areas and they find a new area that's concerning. 16% of the time, BDD symptoms get worse. And 29% of doctors in one research have received complaints, threats, or litigation from a dissatisfied patient. And so it's not only in the interests of the patient to be thinking about BDD, but also in the practitioner's interests as well. And so here are the guidelines. I won't really go through them because Amanda's done a great job at that. Just the key difference between surgical and non-surgical is that in surgical, you need to document the process and use a validated BDD screening tool, which I'll talk about in a moment. But also point 2.1 talks about expectations, really, what are their motivations, what are their expectations? And when we think about what motivates people, this is, I suppose, all people, not just BDD, so moving away from BDD for a moment, just what motivates people to get a cosmetic procedure? Sure, this research shows that 83%, the primary focus, or the primary reason is they just want to look better. And who wouldn't, right? I mean, looking better is associated with all sorts of upsides. Even primary school kids get graded better by their teachers if they're good looking. I just couldn't believe that. So yes, good-looking primary school kids get better grades just because of the bias of primary school teachers. So being good-looking is obviously an advantage in life, and I'm certainly not going to deny that. And this is reflected in people's motivations. They're saying, I want to look better, but I also think it's going to make me happier. 57% of people are going to think that it's going to improve their social life in some way. And 55% of people are saying, I'm doing it for some advantage at work or at school. So it's not just they want to look better. It's also this sort of psychological and social motivations as well. But of course, satisfaction with one's appearance does not have a linear relationship with how good looking you are. For example, the guy on the right, he's not a very good looking chap, but he's a guy from the UK who says that he's very satisfied with his appearance and doesn't really care. And if you look at the research over people's lifespans, dissatisfaction peaks in people's teenage years, whereas in their teenage years, they're actually the most good looking they'll probably ever be. But in their 90s, 90-year-olds are not that good looking. 90-year-olds are often very satisfied with what they look like. So satisfaction with appearance is not strongly related to what you actually look like. And I bet you've seen this in clinic as well, where you think you've got a really good aesthetic outcome for someone, but even though you think that person looks great, and they do, they're not satisfied. And that's not because anything to do with what they look like, that's to do with their psychology. So let's think about how to identify psychological risk factors. So one of the biggest ones that is a predictive of dissatisfaction with procedures is body dysmorphic disorder, as I've shown on previous slide, but also any sort of psychopathology, particularly OCD. OCD and BDD are actually really closely related. For example, OCD might have like obsessive rituals like washing hands. BDD, the obsessive ritual, is often mirror checking. And there's genetic links, and when we did our MRI research, we couldn't distinguish between the OCD brain and the BDD brain. And they're both anxiety disorders, but also depression, eating disorders, personality disorders are also risk factors, and also perfectionism is a risk factor. And looking around this room, I imagine that some of you are perfectionists, and I think that probably in your job, being a perfectionist is probably an advantage, because there's research showing, for example, that perfectionists are better able to identify asymmetries, better at visual analysis, which involves details. And so being a practitioner, being a perfectionist is probably great. Being a patient, perfectionism is a risk factor for dissatisfaction. Also having unrealistic expectations. When a patient says, if I get this procedure, my whole life will be amazing, everything will fall into line, my relationships will improve, I'll look amazing, people will look at me when I walk down the street in awe. That's a risk factor. Having extrinsic motivations. So there's a difference between intrinsic and extrinsic. Intrinsic motivations are saying, I want this procedure just for me. That's predictive of satisfaction. An extrinsic motivator is saying, I'm getting this because my partner wants me to, my work wants me to, I think it's going to help me with this external goal I have. That is shown to be a prediction of less satisfaction. And if someone's got a poor understanding of the risks and benefits, and also excessive social media use is a risk factor. And so how do you assess all this? It's really difficult to do that. You'll be having relatively short consultations, and so it's hard to do. And so that's why I think the easiest way to do it is with a simple questionnaire. If you scan that QR code, we'll send you a PDF copy of the BDD QAS, which is a really short one, but it'll also include some information on the Cosmetic Readiness Questionnaire, which is one that I've created with Dr. Tony Picus, and we hope is going to be the standard. It takes about 5 minutes to complete, and it assesses body dysmorphic disorder, self-criticism, psychological distress, perfectionism, and importantly, openness. Openness as in honesty. How real are these answers, or are they sort of making them up and just ticking no to everything? And what the Cosmetic Readiness Questionnaire gives you, and also how I'd encourage you to think about risk, is that there's 3 zones, and about 5 to 10% of people in our research who take this questionnaire score in the red zone. That's really where there's significant risks of dissatisfaction. We're probably complying with those guidelines of referring out to have a psychological evaluation is probably a good idea. And probably the risk-benefit analysis is just not in the patient's favour. Then the yellow zone. This is when some issues have been highlighted. For example, in our questionnaire, just having BDD is not enough to put you in the red zone. We like to be pretty nuanced about it. I've certainly supported many of my patients with BDD to get cosmetic procedures in a safe way. I don't think it totally rules you out. But if you have BDD and you've got all these other strengths, you'll probably still rate in the yellow zone, which is just an indication for you when thinking about it Just think, okay, have I done informed consent properly? Does this person really have realistic expectations? Do I want to take on this risk? And most of the time, you might decide, yes, you'll go forward, but you might put some precautions in place. And the vast majority of people, 70 to 80%, just score green, and there's no identifiable risk. And so here's some of our research data. We asked a whole bunch of people who were seeking non-surgical cosmetic procedures to do a huge battery of questions for us while we were validating the questionnaire. And we found that 31% of people were above the threshold, which indicates BDD, which was pretty high. And we think it might be a sampling bias in that people that were involved with the research are probably just like super keen cosmetic people rather than just typical casual users. And what we find in clinical practice, with a big sample now of over 6,000 people, is that about 8.7% of people are saying yes to the BDD questions. And this is really reflective of the research that's been going on for a decade, showing that, you know, in dermatology settings, for example, about 10% of patients will have some sort of symptom. But that's, again, not saying that just because they rate high on that particular scale, it's a red flag and it's a no. It's really depends on their other patterns of strengths and weaknesses, which would determine whether they were a suitable candidate. And so the question is sort of why is there this difference in research and in practice? And one of the reasons is people are simply lying on these questionnaires. There's no doubt about it. When these guidelines were put in place, what we saw was that in the first weeks, lots of people were scoring positive for BDD, and then they learnt over time how to answer it, and less is scoring positive. And so that's why we think it's important to also measure patient openness. And so we've got essentially a lie scale on this questionnaire. It asks questions like, I'm always a good listener even if someone's boring. If you tick yes, you're a liar. And we've got a few little questions like that scattered through there, and it will alert the practitioner to say, hey, this person is not being totally honest. And you can see that in research, most people are being honest, but in a clinical practice, there's a high proportion of lying. And so if you were to do, in the consultation, if you want to think about the warning signs, have a look at the patient's language. There's strong negative terms like disgusting. Are they saying things like, I want to look normal, but you think they look fine? Are other people telling them they look normal, but they don't believe them? Ask them about their behaviors. What's their relationship with the mirror like? You know, ask them, how many times a day do you look in the mirror? People with BDD are often looking dozens, sometimes hundreds of times a day. If they come in with a photo library of themselves from different angles, or all the celebrities they want to look like, that's probably a risk factor as well. If they're really well researched about everything there is to do with the procedure, and you think, oh gosh, this person knows more than me, it might mean that they're a bit obsessive, which might be also a warning sign. If they're tearful, anxious, defensive, or, and this is the really hard one, if they're really desperate for the procedure, you can just tell there's this sense of urgency. They just really want it. Unfortunately, and this is why I think your job is honestly so hard, the people that are most desperate sometimes are the people that will benefit the least from a cosmetic procedure. So it's really important to think about this, and if you do notice the warning signs, how to refer. And I'd encourage you to think about the referral process. What psychologist or GP or psychiatrist are you going to refer to? And when you're doing it, really relating to the patient, saying, I can tell how anxious you are. Reassure them, say, I care about what you look like and I care about you as a whole person. And then the hard bit is refusing the treatment on that day with some people and saying, based on our consultation, I'd like you to speak to someone external to see if now is the right time for you to get this procedure. You're not saying, no, I'm never doing it, you're not appropriate, there's something fundamentally wrong with you. Often people with BDD and other psychopathologies feel a sense of defectiveness anyway. So don't say that. Just say, I just want to know whether now is the right time and this person I'll refer you to can help us understand that. And so what a psychologist will do, and there are a few psychologists working in this area, and the information on your table talks a little bit about how you can get in contact with some of them. Don't refer them to me, please. Is that they'll do a psychological evaluation, they'll write you a letter, and then they'll provide some recommendations for that person. And what we're finding is that about 16% of people that get referred to us after probably screening red on the questionnaire, 16% of people we're saying they're very high risk of dissatisfaction with the procedure. 33% we're saying a moderate risk, but probably with accommodations or some extra support they can get through. And 57% of people who are referred to us, we're saying absolutely fine. So the key message is most patients experience a great deal of psychological benefit from cosmetic procedures. It really does make people happier, but there are some where it just doesn't work, no matter how good you are as a practitioner. So be prepared with the screening questionnaire and referral pathway. And the best way to manage that patient that keeps you up at night and makes your job really difficult is to prevent it in the first place. Thank you.